DCEG is committed to both improving the diversity of the workforce as well as improving the diversity of the populations that we study. Ultimately, these efforts would help bridge disparities in health outcomes.
Let's look at your slides on the liver cancer project.
So we see the prevalence for HCV when we look at race, ethnicity. Hispanic individuals had the lowest triply infected rates with HCV, HPV, and HIV, and then non-Hispanic Black individuals had the highest co-infection rates when we looked at race, ethnicity, but we see...
We focus on important scientific questions related to very important disparities that we clearly are aware of and some that we're not aware of, and that's part of our charge.
We have the fellows and a DCEG-wide health disparities working group to look at alleviating health disparities from different perspectives.
We understand cancer, we understand how to do surveillance research, but we really know that we need the perspectives of the populations that we're studying.
Having diverse populations will give us more variability and also, a better understanding of all the different factors that play a role in cancer development. There are different prevalences of risk factors in Africa, so it'll give us a better understanding of the natural history of breast cancer.
We're investigating the relationship between PFAS levels and kidney cancer risk in the multi-ethnic cohort.
The graph that we have here with our cohort is a very classic phenotype-first approach because they're ascertained.
Most of the LFS studies so far have been conducted in white populations, and in these cohorts we have the inclusion of individuals of different ancestries.
What people usually do when they start looking for answers, they're looking at a database. But the database may not have all the answers because it's incomplete.
I work with these large data sets, and unfortunately, when I want to look at various cancer outcomes among racially minoritized populations, this is such a small count, it's so limited, it hinders my ability to truly assess differences in risk factors.
The problem was the big picture for understanding how the diseases work from the data point of view. The data need to be complete.
This is what I admire about the Connect for Cancer Prevention studies, that it takes into account various socio-demographic characteristics.
Race, ethnicity, age, income backgrounds, urban and rural areas. Connect is really the next generation cohort.
What we also do is take that knowledge back into the population. So it really is a cyclic process. Are those screening methods working? Are there things that we can do better? That impacts the population. How that improves, again, circles back to what can we do better.
That's the beauty of DCEG. We're getting all this evidence to put together for the goal of informing policy or informing interventions aimed at reducing disparities in cancer outcomes.